Good morning, everyone. Hello. Is this one's working? No? Good morning, everyone. There we are. If I could get Dr. Beasley and the fantastic Leslie Walcott and Kim McNeil up to the front. Thank you so much for joining us today, everyone. We want to give a warm welcome and say happy National Rural Health Day to those both in the room and online. We are excited to present today's program for North Carolina's National Rural Health Day. The theme this year is Homegrown Connections. I want to go to the next slide. Here we go. Ooh, there it is. And the next one. And Leslie, you want to come up front? We've got some housekeeping for our folks, both in person and online, and I'm going to hand it over to Leslie.
Thank you, Justin. I'm a former comms person, so I was trying to take his picture. So we have a great number of people online, including at least a couple speakers, and we have all of you in this room. Thank you for being here. So if you're online, you are muted currently and you're in listen only mode. Please use the chat, which Kim and I are monitoring, to comment or ask questions, and you can use the call in feature if you're having any trouble. And then for those of us in the room, please use your microphone. We have lots of microphones. We're so thankful for the great tech setup here. We want to make sure we're using the microphones so our online participants can hear us. Red means it's muted. I've got a muted one. And green means it's working. And restrooms are out the door and to the left. And I know a couple employees were worried about coming in and out. Please come in and out as you need to. We'd rather have you here when you can be here. And of course, patients come first. So please go take care of them as well. And yes, take care of your needs. We will record the presentation and we will share all the PowerPoint and resources after the meeting. So don't worry and try to write everything down. We'll get it to you. Thank you for being here. And I think next up is, sorry. You can do that?
And next we'll invite Dr. Beasley up to the front.
Oops. Good morning. The North Carolina Office of Rural Health was founded 51 years ago, long after the state of North Carolina was established, and even longer after the land was settled by the native people who originally inhabited this land. This American Indian Heritage Month, we would like to take a moment to appreciate and acknowledge the Lumbee people, whose land we are currently standing on, along with the many other native tribes across the state of North Carolina who live, work, play in rural communities we all call home. The past, present, and future of the Lumbee people and all native peoples across the state of North Carolina are rich and diverse. And you may not realize that North Carolina has the largest native population east of the Mississippi. The Lumbee tribe is the 9th largest tribe in the state. That's not in my comments originally, but we encourage those in our audience to take time to educate themselves and learn about the Lumbee people by visiting the link on the slide. Additionally, we invite you to learn about the native lands in which you currently live by visiting the second link attached. Together, we can take a step in the right direction by honoring not only the native people, but the enslaved people, the indigenous, the indentured people, all the people who helped settle this land we call home and continue to move forward together. Thank you.
Thank you, Dr. Beasley. Good morning, everyone. I'm Kim McNeil. And as you can see, we have our learning objectives for this morning. we hope that when you all leave here today, that you will leave with increased knowledge about our State Office of Rural Health, as well as other key federal, state, and local partners, but also learning about increasing knowledge about innovative approaches and all things rural, and tapping into local resources within your community, and those homegrown connections, being able to make homegrown connections is something that we heard about this morning at our breakfast for Scotland Health and all the things that they're doing with their nursing program, and what they're doing to recruit and retain nurses. So next slide. Here's our agenda for today. Our planning committee has put together an action-packed event that we hope will be informative as well as interactive. So of course, what would a meeting be without a group activity? So there will be a group activity, so get ready for that. So don't be mad, okay? We told you. But we have lots planned for today. I won't go through all of it, but we will have our community star. We'll have presentations today. We'll have panels. We'll talk about Medicaid expansion. We just hope that you all will leave here today with you've learned something new from today's event. So thank you so much. So I'm going to turn it over to David Pope, then David Reese, and then Allison Owen.
First, let me just say welcome to everybody that's here, and particularly for the folks that are online. This is a great opportunity to be able to meet new friends that share some of the same challenges that we do. It's also an opportunity to catch up with old friends and to be able to share some of the partnerships here in southeastern North Carolina that we've been able to form, and some of the, I think, neat things that this area has done in terms of addressing some of the challenges. You know, I remember from being a kid in Vacation Bible School, we sang that song, you know, This Little Light of Mine. And so there's a part that says, you know, hide it under a bushel. No, we're going to let it shine. So I think that this is a good day for us to be rightfully proud of the good work we're doing while acknowledging the challenges that we still have, with the hope that some of the things we talk about, discuss, share here today will be things that help folks in North Carolina in rural places all across the state. It's also a worthy time to just reflect on the legacy of Jim Bernstein, who 51 years ago started the Office of Rural Health, first in the nation. And one of the things from this morning's breakfast that we talked about was the importance of going to a community and listening to the people in the community, understanding their needs and also their solutions. And if you don't have that connection, if you don't have that motivation, then that's not a place where it's probably fertile ground to work on. I've also personally benefited from the legacy of Jim Bernstein. Our keynote speaker here today, Dr. Tom Ricketts, I've had as a professor twice, a boss, ship's captain a couple times. And I have it on good authority that Tom, when he was finishing up his graduate work and trying to decide where he was going to make his mark, was influenced by Jim. And so a lot of the blessings that this state has seen through his work and through the work of other people that Jim influenced is a direct legacy to that. So I've got 3 quick points, like any good Southern Baptist preacher, but I'm going to try to get through them. So the first is, what's the challenge with rural health? And so I want to take you on a road trip. So if you start in Mecklenburg County, the average life expectancy there is 80. If you go to Union County, where I'm from, which now is a bedroom community of Mecklenburg County, the average life expectancy is 80 years as well. If you move on to Anson, it's 73.4. Richmond, 73.1, Robeson County, 71.7, Columbus, 73.5. And then you get back down towards the coast, Brunswick County, which has become a bedroom community for Wilmington. It's back up to 79.2, and then in New Hanover, it's 79.1. So if we take Mecklenburg County as being representative of an urban area, and we take just Scotland, we don't even go to Robinson, we take Scotland. That's 7 years difference on average in how long folks are going to live. So here's the gut check. I want y'all to think back about your life in the last 7 years. And I want you to reflect on all the good things that you've been able to experience. How many births? How many graduations? How many marriages? How many vacations? How many good times together have y'all had with your families? And particularly as we think about the seniors that are members, the elders that are members of your families, how many of those things were shared with them? So 7 years
I can get it through my
matters.
phone.
7 years can be a big difference.
Phone.
Right? How do we be better than expected so that folks that come to a small community hospital with 104 beds get an experience that's better than they expected? Most of all, how do we make sure that our patients get better? And then finally, as I think about the other thing here that we really harp on is our 3 True North commitments. How do we do the right thing for the patient? How do we take care of our people? And how do we make the right decisions for our communities for the next 30 years? So why does it matter? Okay, and this is a tale of 2 tomatoes. So if you've ever been in October to Walmart or to the supermarket and have bought a tomato and brought it home, it is usually bland and tasteless and chewy. And 2 weeks ago, we had a leadership training, and we were out here with our leadership team. And one of the local ladies that we use, who's from Bennettsville with MacArthur Farms, was catering that. And so she had set out some sandwiches, and we're eating club sandwiches. And everybody is talking about how great the tomatoes on the sandwich are. They're red, they're juicy, they're flavorful. They're the exact opposite of what you would get if you went out to buy it at a supermarket. And so when I asked her about it, she said, I grew it. Okay? So how am I going to try all this to pull this all together, right? So I would urge you, I would exhort you that I think what makes North Carolina bright, juicy, flavorful is the stuff that's coming from the rural areas. Our urban centers have become more homogenized as folks have moved into the area, right? The things that have been distinctive about North Carolina, the things that I think really make us special and good, are still most often found in rural areas. And here's the proof for it. If you don't believe me, think about just take one element of American culture. Think about what American music would be like if these folks and the communities that they came from had never existed. Doc Watson, who came from Deep Gap. John Coltrane, who was born and grew up in Hamlet. Randy Travis, that's from Marshville, close to where I grew up. Dizzy Gillespie, who was born in Sherall in South Carolina, but studied here at the Laurinburg Institute. Earl Scruggs, who revolutionized the way that we played the banjo in America, and along with Bill Monroe, who was from Kentucky, created bluegrass music. He was from Flint Hill out in Cleveland County. Nina Simone, who grew up in Tryon in Polk County. And then finally, I'll end with George Clinton, possibly the funkiest man ever to have lived, who was from Kannapolis. So why does it matter? I think it matters because what happens in rural areas, even though we have challenges, it's really good stuff. And for the people that choose to live in rural areas, that love these places, we need to make sure that there's a future and a legacy for them. Thank y'all.
Good morning. David, that was great. You listed all the folks born like all in the region by memory. Good morning, everyone. I'm David Reese, I'm President and CEO of the Foundation for Health Leadership and Innovation. And today's a good day. You know, today's the day we think about rural and what rural means. And, you know, as we go through the day and you're going to have presentations and you're going to learn new things, one of the concepts I want you just to hold on to is the power of rural, right? And, you know, David talked some about that, but I want you to hold on to the power of rural, especially as you think about how we do our work. So I bring you greetings from our FHLI board, from our staff, from our partners throughout our 100 counties. I also am very, very thankful for Scotland Health Care System. Thank you all for opening your doors this morning, allowing us to come into your space, to really be in community, and that's part of what rural is. Also, thank you to the Office of Rural Health. You bring us together. You create the community that is just so powerful, so important to us as providers, as parents, as partners, as just those folks who think about the health and wellness of North Carolina. I also want to take a moment to acknowledge, and I'm talking to our folks online, acknowledge our community members in Western North Carolina. I want to take a moment and acknowledge their resilience, acknowledge their determination, their commitment back to their community to rebuild. You know, us on this part of the state, I mean, we understand what disaster looks like. We understand what hurricane looks like. And so we understand like part of what that rebuild is and how difficult that is, but also how it brings rural communities together, right? And how it just really, I think, peels back all of the places where we don't agree and brings us to the places where we do agree. And so for our neighbors in Western North Carolina, I want you to know that we're thinking about you, that we're continuing to work with you, and continue to do what you do because you're inspiring to all of us. We talked a little bit about Jim Bernstein. You know, Jim Bernstein created the Office of Rural Health, also created the Foundation for Health Leadership and Innovation. And part of what he believed was that community mattered, that we actually had to engage the community, ask the community what was important to them as they thought about how they addressed their social drivers. And so from an FHLI perspective, this is the place where we come back. We come back and we then really embrace what our community says as our community starts to really begin to think about, well, what's important to me as I think about my health, as I think about the health of my mother, the health of my aunt, the health of my father, the health of my children, what's important to me? And I believe we have this responsibility to then walk alongside community as they begin to just identify what's important to them. And so part of that also requires us just to be innovative. And so you're going to hear a lot about innovation today. You know, I hold innovation near and dear. It's in the name of our organization. But, You're going to hear about innovation. You're going to hear about innovation from the health system. You're going to hear about innovation from a lot of other partners. And if you take one or two things away from today, remember the power of rural. And then I also want you to take away the innovation and what is your role, our role, in continuing to innovate as we think about healthy rural communities. Healthy rural communities just don't happen. We know that. Just doesn't happen. It's something that requires action from us. And so you have your two charges, right? Power of rural, and then where do we innovate as we think about the health and wellness of our rural communities? I want to thank you for today. I want to thank you all for being in this space. And I want to congratulate you. Right? Today's a day of celebration. Congratulate you as we think about our next steps and where we're going together collectively. Good morning.
Good morning, everybody. On behalf of our director, Maggie Sauer, and the Office of Rural Health, I want to extend a huge thank you to Scotland Healthcare System. Oh my goodness, what an incredible day. And I also would like to acknowledge the planning committee. If you all could please stand up, don't just raise your hand, please stand and be recognized. This day has been a long time in the making. I think it started maybe last year when David reached out to Doretha Brock and said, I want to host next year. And so the team has been coming together probably since the summer, I would guess, to plan today. And so I would be remiss if I didn't give a particular shout out to Doretha Brock, who is the Rural Health Operations Program Manager, whose name I just mentioned. Doretha has really been phenomenal and instrumental in helping behind the scenes. She could not be here today, unfortunately. She's very sad about that. I do believe she's online. So Doretha, thank you. Today is going to be spectacular because of you and the planning that all the group has done. As has been mentioned, you can change the slides. We're just going to tag team this a little bit. Today is the 14th annual National Rural Health Day. And even though the power of rural is kind of the national logo or slogan, today's theme is about homegrown connections, and you've heard that before as well. A little bit of history about the National Rural Health Day. So back in 2011, our National Organization of State Offices of Rural Health said, we want to set aside a day to recognize the 61 million people across this country who live in rural places. Over 3 million of those are right here in our state. They decided on the third Thursday of November, and not only to celebrate rural communities, but to recognize in particular the rural healthcare providers who help to make healthcare, quality healthcare, accessible no matter where you live. So I'm going to be talking a little bit about how our office and our department connects and how we make these homegrown connections. The first way that I would like to mention, you've probably heard a little bit about this, something called Medicaid expansion. I grabbed this from the Medicaid expansion dashboard. There's a dashboard. You can go on there online anytime to see and filter. You can see all these different ways you can filter and see the statistics around how North Carolinians have been connected to healthcare through Medicaid expansion. This statistic was taken November the 3rd, and you see 569,000. We are up to over 577,000 North Carolinians who now have better healthcare through Medicaid expansion. We will celebrate 1 year of being a Medicaid expansion state on December 1st. So that's a pretty significant milestone when you think about our target was 600,000 North Carolinians over multiple years. We're almost there, and we're not even a year in. So thank you for making that happen. Okay, next slide, please. So how does the Office of Rural Health make homegrown connections? I'm going to talk about several ways we do it. The first way is through funding. This statistic, last year we gave out over $34 million in grants and contracts, and that's about 85% of the total funding that we receive. So we are very proud of the fact that of all the money we get, we give out 80 to 90% of it back in rural communities to support you on the work that you do. That 34 million represents 441 active grants with organizations and 310 active contracts with providers who join to practice through loan repayment contracts and high needs service bonuses. And you'll hear a little bit more about that with a panel coming up later today, but that's significant. Okay, next, please. We also connect through training. I've highlighted a few of our programs because I wanted to focus on some of the training that we provide. Our Health Information Technology team, or our HIT team, provides training with helping organizations connect to NC Care 360. Are you all familiar with that? Okay. So that's a platform that provides that closed loop referral if you have a patient who has needs outside of the clinic that can really improve their health, like access to food, access to housing, access to transportation. So our team can help support the work that the foundation does with NC Care 360 and helping to train organizations. We also have a generous grant through the Department of Information Technology, the Office of Digital Equity and Literacy, to provide digital skills and health language training. So this is kind of a train the trainer model where we develop a curriculum and we work through community paramedicine programs to train organizations, again, individuals, around building out those skills so that they're not afraid to access technology and they understand how to access their charts and how to do it safely. We also have digital equity champions, and those are organizations or individuals that help patients understand how to access telehealth and internet resources. Our Farm Worker Health Program trains outreach workers so that our agricultural workers understand they can have access to healthcare and they understand some of the challenges and some of the risks inherent in their jobs. Farm Worker Health Program has also received through the Department of Information Technology this digital skills and health language grant. And so they're using community health workers to be those digital equity champions to explain to farm workers and agricultural workers how they can access telehealth to improve their care no matter where they are. And then our Rural Health Operations team provides training around performance measures and improvement. I want to give a shout out to our Area Health Education Center's practice support coaches. I saw Ms. Locklear earlier. If you haven't connected with your AHEC practice support coach, you need to. They provide incredible direction, guidance, training. We were talking earlier this morning about billing and coding resources, so please reach out. They're everywhere across the state. We can connect you if you have questions about that. Next, please. The Office of Rural Health connects through technical assistance. We track this very carefully because we believe that it's important to support you all in the work that you do. Last year, we served over 700 organizations and providers in areas like recruitment and retention assistance, site development, process improvement, contract development, or clinic assistance. And finally, we connect through partnerships. Today, we're so excited to be here, Scotland Healthcare System. Incredible partnership. We've really enjoyed our relationship that we've developed more strongly over the last year. Certainly our Rural Health Association and FHLI and you. I mean, every single person in this room and everybody online is a partner to us. We could not do what we do without you. So sometimes this work feels lonely. Sometimes it feels like I don't have anybody out there who understands me. Look at all your partners. You probably know these, but if you need to check that out on our website, you can do that. But you're not alone in this work. And again, your support and your partnership is so valuable to us in our work. Next slide, please. So if you want to visit our website, I put the link up there. And these are some other programs that our office has, all of them equally important, all of them helping with the same mission, and that is to increase access to care in rural parts of our state. So without further ado, let's celebrate. Thank you so much.
Next, we will hear remarks from Governor Cooper. One moment. if I do this?
Hi, everybody.
Oh.
Hi, everybody. Governor Roy Cooper here. Happy National Rural Health Day. North Carolina's large rural population that lives in small towns and countrysides across our state are an integral part of our state's identity. We also know these areas present unique challenges when it comes to health care. I'm so grateful for the work being done by healthcare workers and providers to increase rural access to important healthcare resources and care. Your efforts are making a real difference. Last year, we celebrated the 50th anniversary of our North Carolina Office of Rural Health, and we finally expanded Medicaid. Medicaid expansion is changing lives in rural North Carolina, helping keep hospital doors open and getting quality, affordable health care to more folks in rural communities. There's still much more to do to increase rural access to quality health care, but I'm proud of the progress being made by our Department of Health and Human Services to advance health equity across North Carolina. Thanks again to the healthcare professionals providing quality care to rural North Carolina.
Can you hear us now, Maggie?
I can hear you.
We're going to hand it over to you.
Okay.
Thanks.
Good morning, everybody. Sorry I can't be there with you today, but this is such a wonderful day to celebrate. And it's a real honor to begin to think about the proclamation and what this day means. And to my colleague, Doretha Brock, who knows I get long-winded, I am definitely going to stay on script today. So I just wanted to assure you. The proclamation is something that I think is important for all of our organizations, because it really does represent with the reading the people and the organizations and the community members that are part of this proclamation, and also making sure that the work in our rural communities continues to happen And it is those deep connections. So just as a point of introduction, Precious McCarn is going to be reading part of this. She's from the Scotland Healthcare System and also a community health worker, Dr. Beasley, who you've heard a bit earlier. And so wonderful to have you there, Dr. Beasley. Ms. Carnato, and I apologize, from the Carolina Hunger Initiative if I did not pronounce that correctly. Cindy O'Boyle from Community Care Clinic of Franklin, Dr. Gibson from Pelata, and I'm sorry about, I know I butchered that name, but I know that they have been doing so much work through COVID and through so many other outreach activities. And then Vanessa Sanabria from Surrey Medical Ministries, Dr. Harrell, who is a leader, who is a Bernstein fellow and is now at the Foundation for Health Leadership and Innovation. You'll hear from Honey Estrada, who is also the president CEO of the North Carolina Community Health Worker Association, Ruben Blackwell from OIC Rocky Mount, who is also part of a community health center there, and then Dr. Shelley Lowry, the Scotland Healthcare System. So I'll turn that over to the team, but thank you so much. And Tom Ricketts, I'm so sorry I'm not there to hear in person, and certainly to William Massengel, who is such an amazing leader and so instrumental in the work that's happened in the Benson healthcare area. So thank you. Have a wonderful day. I'll be online and so excited for this day and for all the energy that you bring to rural North Carolina. Thank you.
Whereas rural communities in North Carolina are wonderful places to live, work, and play, they are enriched by the diverse people who call rural North Carolina home. And
whereas North Carolina has the second largest rural population in the nation, and
whereas the rural healthcare system is an important economic foundation of their communities, and
whereas rural healthcare providers, including doctors, nurses, and support staff, are dedicated professionals who serve tirelessly to ensure the health and well-being of rural populations, providing comprehensive, compassionate, patient-centered, and holistic care to patients. And
whereas meeting the healthcare needs of our state is constantly evolving as each rural community faces unique challenges that they address to improve the health of our state now and in the future. And
whereas while we acknowledge our community's healthcare challenges, we also recognize and celebrate our spirit of innovation as we improve access to and quality of care for all our neighbors. And
whereas achieving health equity and eliminating health disparities are essential to ensuring that all North Carolinians, regardless of their geographical location, have access to high-quality healthcare services. And
whereas it is imperative that we continue to support and invest in the health infrastructure of our rural communities to ensure that all North Carolinians have access to high-quality healthcare services. And
whereas the North Carolina Department of Health and Human Services and the North Carolina Office of Rural Health, along with other interested agencies and organizations, recognize the unique healthcare needs and opportunities that exist across our great state, and celebrate our healthcare communities, organizations, and providers for the valuable services they continue to provide.
Now, therefore, I, Roy Cooper, Governor of the State of North Carolina, do hereby proclaim November 21st, 2024 as National Rural Health Day in North Carolina and commend its observance to all citizens.
Okay, there we go. Can y'all hear me? Okay, good. Had to make sure I pressed the button. So I have the pleasure of introducing this year's Community Star. So since 2015, the National Organization of State Offices of Rural Health, also known as NOSOR, has recognized individuals and organizations that have made impacts within their rural communities. So this year, our Office of Rural Health chose William Massengill as our Community Star. He's the former CEO of Benson Health, and I've had the pleasure of working with him for the past 3 years. So I got to witness firsthand the passion that he has for the rural community, the patients of Benson Health, as well as the staff that he worked with closely for so many years. So I want to welcome William, the Community Star, William Massengill.
Thank you for letting me be here today and say a few words. And I want to thank Maggie, Doretha, Allison, Kim, and the whole staff of the Office of Rural Health, because they really are lifesavers in a lot of ways for our rural communities as support, as means of income, as other ways to lift us up and help our rural communities. Being here in Laurinburg is special to me because one of my mentors when I graduated from social work school was from this area. And she loved this community, and she was just very special to me. So I'm thinking of her today as I'm here. You see, I'm a product of rural North Carolina. I grew up in the small town of Benson. I currently live on Main Street. I spent summers working in tobacco and helping my family bale hay on our family farm. And I went with my granddaddy to the tobacco market during the summers when I was in college. I spent my life living in Benson, raising 2 grown children, and living with some of the most kind and generous people I've ever known. And I've spent my entire career working in healthcare. Not only working to ensure access to care for rural people, but working side by side with people like us who were raised in rural North Carolina, people who may not have formal education, but at the same time are some of the most brilliant people I've ever met in my career. Sometimes I think rural people are like a lot of groups. They get stigmatized. Assumptions are made, and they get marginalized. I don't have to spell those things out to you because you already know what they are. But what I've learned is that while our rural areas are diverse, I found some things that I think sort of exemplify our rural communities and the people who live there. So I just want to share with you a few of my observations that I've gathered throughout my career, my lived experience, and my service on boards. Number one, rural people are diverse, and that diversity makes life rich in rural communities. Racially, economically, and educationally, when you live in a small town, you don't live away from anyone. You literally live down the street or down the road. Within a few blocks can live the richest person in town and the poorest. A local doctor and the nurse's aide at the local nursing home. A white family who has lived here for decades and a recent immigrant family to America. We see everyone at the local grocery store because we're not choosing between Whole Foods and the Piggly Wiggly. We're all going together to the IGA. It's there that we see our neighbors and we are reminded of the vast richness of the people who live around us. Our children see this richness. It's one of the reasons I've chose to raise my children in Benson. Because of that diversity up close, they're better people for it. Rural people see value in everyday things. The young man and sometimes young women who like to hunt and fish, they may not call themselves environmentalists, but they are some people who have the most profound love and respect for the land that I know of. We enjoy movie night at the local park and the local fall festival where everybody cheers on the local band and the floats of the school children. And one of the things I've learned is that rural people know how to problem solve. They can sometimes be attributed, that can be attributed to the fact that there are a lack of resources. But I think it can also be part of a culture of self-reliance. The idea that we take care of our own. I serve on the local hospital board, and I have seen firsthand how the staff in our hospital have been leaders in innovation, sometimes making improvements or creating new processes later developed by urban centers. And I'm sure that probably happens here at Scotland also. Rural people don't give up. My favorite story is when Benson Health went on electronic health records about 10 years ago. We had people who had never cut on a computer. Many of these people had grown up on farms and lived in the community. Computers were not as widely known or smartphones. But what I realized in that was that there was a clear evidence, a tenacity, that they were not going to be beaten by the challenge. They were not going to allow their lack of knowledge or experience to overcome them. You can call it pride. You can call it tenacity. I call it grit. And it runs deep in rural people. The other thing I noticed is that rural people are generous. Generosity in giving their time to the local church or house of worship, local food pantry, civic club, donation to the local high school booster club, or supporting the annual Christmas toy drive. A woman that I greatly respect, she was a lieutenant colonel in the military. She grew up in Benson, and she told me one time when we were doing this fundraiser, she said, "There's nothing that the people in our church can't do if we want to do it." That spoke to me. Not only it showed the experience she had had of what people could do, but it spoke to her faith that people could continue to do it in the future. Rural people have a rich history. It's not perfect. Some of it relics of the past we wish to forget. But that memory can remind us of how far we've come. But for the people here today, you, the people I'll call the helpers, the people who live lives to make a difference, we are reminded that knowledge and wisdom may not always come just from the ivory tower or the large institution. It may come from the local farmer, the shop owner, the small business owner, the farm worker, or the person cutting our hair, or the staff, the providers, and leaders at the Rural Health Center. I want to say that having spent almost 5 months not working in the role that I was in as CEO of Benson Health, and now working part-time as a clinical social worker, I've learned a couple of things and reflected. Number one, I've now, through telehealth, worked with people all across the state. And what I've seen is that when you take away the money, the socioeconomic class, the education, the skin color, all those things, everybody wants the same thing for their children, for their families. We all have the same hopes. We all have the same fears, worries, anxieties. It doesn't matter. And I think that's the thing that unites us as people, particularly y'all who want to go out and serve people. I also have realized a couple of other things, that we need to be gentle on ourselves. What you're doing is hard work. I didn't realize the stress of it all until I'd walked away from it. But it's there and it's real. So I think we need to remember to ask for help. I think we need to remember to nourish our soul. What is that thing that gives you pleasure, that brings you peace, that brings you joy? We need that in our lives. Probably now more than ever, because it doesn't get any easier. But the work is important. And I think that's what I realize, that the work that we do as people serving rural North Carolina saves lives. And it makes a difference in generations of people. So on this Rural Health Day, I want to honor and say thank you to the healthcare leaders of rural North Carolina, particularly the people I think may be listening from Vincent Health. Some of the most hardworking, innovative, intellectual, smart people I know of. And thank you for what you're doing and for your service to our state. Thank you.
Next, we'd like to invite Deputy Secretary Deborah Farrington for her welcome and remarks.
Although I will say, William, that's a hard act to follow. But your words were inspiring, well-spoken, and I look forward to following in your footsteps in retirement one day soon. So it is my pleasure to be here to celebrate National Rural Health Day. This is an opportunity for us to celebrate, I think you heard it mentioned earlier by David, the power of rural. It's an opportunity for us to reflect on the unique challenges that rural communities face. You heard David Polk speak about some of those. But it's also a time for us to remind ourselves that we have already accomplished a lot. We have strength, we have power, we have community, and an ability to accomplish much more. There are many challenges that we face in rural communities. And like William, I have the distinct pleasure and honor of have grown up in a rural community, and I'm incredibly proud of the places that I've come from. I remember being at a National Rural Health Celebration Day a few years ago, and I think it was the gentleman from the Rural Health or the Rural Free Clinic Association said that some people refer to our small towns as the middle of nowhere, but I call it the southern part of heaven or something like that. And I've cherished that because as many of you may travel to Myrtle Beach, heading down through Columbus County, you're likely to go through my small town of Chadbourne, and there's not much there. But for me, it's that little piece of heaven that I love so much. I'm so thankful that we have an opportunity to celebrate this theme of homegrown connections because it's something that reminds me of all of the things that I love about rural North Carolina. It reminds me of the things that I love about my early life, my family, my friends, my hometown, my identity, and it reminds me of why we do this work and why we have such passion for the work. Part of it is because, as you've heard, rural health is community health. And for North Carolina Department of Health and Human Services, it is the reason that we exist, to improve the health, the safety, the well-being of all North Carolinians, especially those from rural communities who are vulnerable, who face a lack of adequate health care, and who have greater risk for poor health outcomes. And that's why our Office of Rural Health exists. I ask our Office of Rural Health staff to wave your hand. It's why you exist. And it's why we celebrate all that you do, being the first office in the nation that was created to focus a lot over the last 10 years. We will continue to see our rural communities being transformed into urban areas, but still the vast majority of our community members live in rural North Carolina. And for that, we're happy. Our work is important because we face many challenges. I think David Pope mentioned earlier that we are more likely, if we live in rural areas, to die sooner than our urban counterparts. We're more likely to die from the leading causes of death, cancer, heart disease, stroke, some of those unintentional injuries. We face health disparities. We have limited access to specialized care, limited access to emergency rooms. We're exposed to environmental hazards and have higher rates of poverty. Within rural areas, we see some populations that suffer even more. Members of our American Indian communities, our veterans, people who are pregnant. And as an example, you've heard about the fact that many hospitals are closing their obstetrics and gynecology centers. And as those hospitals close those services, we see increased rates of risk from mothers in maternity care. We see increased infant mortality. I read a statistic in thinking about what I would say today that said that more than about half the hospitals in rural areas lack access to obstetrics care, and that by 2030, the anticipated supply of OBGYNs is expected to only meet about half the expected needs. And where there's no obstetrics care, we see higher preterm deliveries, we see poor maternal and infant health outcomes. So we can't be satisfied with that, because these more prevalent negative outcomes exist in our rural communities. We see challenges, obviously, with rural hospitals closing, and we're so happy that Scotland Health is still here to serve this rural community. We see lack of access, which means people will have poor health outcomes. We see challenges of broadband access, so that when people try to access that telehealth service that's being offered, they're having trouble doing that. We see challenges in our workforce. And so there are many things that we face as challenges. And so why do we go forward to continue to do this work? We go forward because we have an opportunity to make improvements. In fact, we already have. Allison talked earlier today about what we've done with Medicaid expansion. That's a result of all the work that you've done, the work of people in rural communities. We are making improvements in access to care. There's more to do, but we have made tremendous access. We're seeing millions of dollars, as Allison referenced earlier, being given to our free and charitable clinics, to our FQHCs, to our primary care clinics. We are addressing the workforce challenge that exists. It's still there, but we continue to make funds available through our loan repayment programs and through some of the other efforts to beef up the providers who are willing to come and work in rural communities. We're doing this because we have strong relationships, and William mentioned it earlier. We care about our communities in rural areas. And so we're here to make a difference. In fact, we already have made a difference, and I know that we'll continue to do so, more so. There's more for us to do. There are many challenges to face, but we're willing to do that because our neighbors, our friends, and our families continue to live in rural areas, and they depend on us to make a difference today. And so I ask that you continue to partner with us to make sure that we can address the health needs of rural communities, and that we can make sure that everybody who lives in a rural area can live out their healthiest life. Thank you.
Next, we want to invite up our panel, which will be facilitated by Stephanie Nance, the Assistant Director at the Office of Rural Health. Along with her will be Dr. Sherry Beasley, Christy Meggs, and Maya Sanders, and we'll let them all introduce themselves from the panel. Thank you. Just remember.
Well, good morning, everyone. Is this projecting? Great. Good morning, everyone. I'm Stephanie Nance. I'm Assistant Director of the Office of Rural Health, and I'm delighted to be here and extend another round of thanks to each of you for joining us and for Scotland County for hosting. I'm going to ask our panel if they could please introduce themselves and describe your role and how it connects to developing the rural healthcare workforce.
All right, good morning. So I'm Christy Meggs, and I'm the Vice President of Human Resources here at Scotland Health. And so my role is to lead the strategy for recruitment and retention and training of a great healthcare workforce to serve our patients and our communities.
Good morning. I'm Maya Sanders. I'm 1/3 of the placement services team with the Office of Rural Health.
I'm Cherry Maynard Beasley, and while it says I'm acting provost, deputy provost at UNC Pembroke, I left that administrative position, and now still working with UNC Pembroke as we're focusing on not only developing the workforce, but also looking at how do we develop researchers, the critical need for researchers in our rural communities. And secondly, I'm also working with the Lumbee tribe to develop their first Department of Health and Human Services.
So Dr. Beasley, as an educational leader in South Central North Carolina, what unique challenges and opportunities do you see for training and retaining healthcare professionals in rural settings?
Thank you. I have been in nursing education, particularly for more than 30 years now, and most of it here in southeastern North Carolina. However, one of the things I want to talk about, we've heard a lot about the unique and wonderful things about rural people. And I obviously believe that because I'm still living in Robeson County, right? So when we think about the diversity, we think about all the things that have already been mentioned, the unique characteristics, who we are. Those are important things for us to always think about, but they are not. Their opportunities and our challenges are almost holding the tension between the two. Because those things that make us so unique and wonderful are also some of the things that make it very difficult for people to come and be trained and educated in our communities. And so that's why the whole concept of homegrown is so important. But I'm going to also ask you to think about some of the implicit biases that are against rural people. And not only for people outside of rural settings, but also within ourselves. Sometimes we think of ourselves as being not quite there. But I'm going to tell you, we are above because we have that diversity, we have that understanding, but yet we also have to learn to deal with our own implicit biases. And then when we think about homegrown, what I want to focus on too is the idea it's not just people who were born and raised in our communities who are going to come here to work. We've got to figure out ways to bring and attract people who've never lived and be in a rural setting before. And so one of the pieces of that is, again, helping them understand, like through things like poverty simulations and dealing with implicit bias, how do you learn to work and understand who you are first so that you can then reach out and help our people? So I think those are some of the most important things when we think about that challenge. You know, yes, we have a shortage. And then we've already heard wonderful people talk about we learn how to do things with much better work with less. We're very creative, we're very innovative, but then we've got to be able to embrace that. And I think one of my drives now for researchers and writers is how do we get that message out so that people want to come and live and work in our communities?
Thank you. Now I'm going to move to Christy. What are some primary challenges you face in recruiting and retaining healthcare workers?
Yeah, so recruiting and retaining in a rural area can be very challenging just because of the numbers of people that are available and the number of programs in the area. So our colleges, we work very closely with our colleges and universities, and they've done a great job, particularly in the nursing area, to try to increase the number of programs in the area and increase the number of students that they are turning out. But in those specialty areas, like in radiology, in our imaging services, and our surgical techs, and our physical therapy, our occupational therapy, those types of areas, that's where we don't have programs in the area. So we're having to get people to come into our areas. So, we're having to look at housing issues within our area, amenities, all of the things that people want. A lot of our students have to go off to school for those programs, and then trying to get them to come back to our areas is often a challenge as well. And so that's where we do feel our homegrown connections also are very important in growing our own, but trying to look at ways that we can help support our local colleges and universities as well to try to implement those programs also.
Thank you. And the next is to Maya. What structural or systematic barriers do you see impacting healthcare workforce placement in rural areas, and what solutions have proven effective?
So I would like to discuss not only recruiting providers, but also considering they're coming with a spouse. They're coming with children. So when the recruitment team or the placement services team goes to national conferences, what we hear a lot of is the provider may be on board, but if the safety net site is not also considering their spouse may need a job, their spouse may have a specific interest, and they have children, they're looking at school systems, they're looking at all of those things. And so then when we're working with sites to post their open opportunities, a lot of times what is written for us to post only talks about what it's going to be like for them from certain hour to certain hour. It leaves out all the other things after work is over. And so I think that one of the solutions would be to make sure that we're all sharing the entire holistic picture of what it would look like when they get here. And I also think that would take away some of the sticker shock of if they're not from the area when they get there and they're looking for the mall, or they're looking for, where's Walmart? How many stoplights did you say? And so just to give them a picture, some level of expectation of what they'll see when they arrive outside of the patient room. Thank you.
Thank you. That's great. And I'll tell a little funny story. Sometimes, we say send pictures for your posting, and they send a picture of the exam room, and I'm like, how about your park or the beautiful view of the ocean or the mountain, or your community, different community outings. So we kind of chuckle about that. So so to all the panelists, could you speak about an innovative program or partnership or funding source that's helping build healthcare with a pipeline in rural communities?
I'll go first. So one of the things that we found is the traditional model of just tuition reimbursement, although we offer that, is not necessarily working. We have people who want to go back to school, but they can't afford to stop working to go back to school. Not only just the cost of school, but also just to support their families while they're doing that. So we have created a couple of programs. One is our Legacy Nurse Scholarship Program, and that was named after our former CEO, Greg Wood, and Workforce Pipeline was very important to him. And so we have created this program. We send our CNAs who are recommended by their leaders back to school, and we make them whole while they're in school. So they work part-time while being paid full-time, and we support the tuition for them. And so that has been very successful so far. We'll see our first graduates coming out this spring, so we're very excited about that. We have 10 nurses in that program right now. And then our newest program is for our RN to BSN. So again, we feel like it's very important to grow our next level of leaders. And so we have to do that from within. So we have just developed a partnership with St. Andrews University, which is right next door to us. And we are paying the full amount of the RN to BSN program. Our nurses will go and complete this program asynchronously online in 9 months. And so they will do that. They will do their community health clinicals with us and be able to do some community health projects with our great community health team that we have. And then they also will do their capstone course with us as well in an area outside of their own, which we hope will provide some further improvements within the system as well. So those are a couple of the things that we're doing. And then just from a, kind of a work-life balance and promoting just that family-friendly benefits too, we are implementing effective January 1st paid parental leave and adoption assistance. And then we also are going to be opening on-site childcare in 2025 for our teammates as well.
Well, the placement services team at the Office of Rural Health offers money for loan repayment. And if we can't give it to you ourselves, we link you with our federal partners at HRSA, the National Health Service Corps. The loan repayment programs offer money in exchange for a commitment up to 4 years. We've had an expansion in funding, which has allowed us to even expand our list of eligible provider types. And that has been amazing. And we've been pushing money out the door as quickly as we can. And I also want to say that behavioral health has been included in that, and that is extremely important. And so one of our responsibilities is to talk to medical students, to talk to providers who may be interested in changing their site. Maybe they want to move. And so we walk them through the process of how to apply for our loan repayment programs that are state funded. Offer them the opportunity. If the state funded loan repayment programs aren't the best fit, we walk them to the federal partners and help them to apply for those as well. And the federal money will allow them to continue to apply for their loan repayment program until their debt is gone, which is a retention tool. So it's not all about recruitment. And to that point, the Office of Rural Health offers a high needs service bonus, which actually is an incentive to retain providers who don't have any loan debt. So if you have a more seasoned provider that you want to bring on board, or someone who was just lucky enough to graduate without loans, we don't know who that is, but but it's available for them to apply. So we look forward to continuing to be able to offer that to providers.
Thank you. Before I respond to the question, I just want to say one thing that's significant as we're thinking about homegrown and partnerships. I actually was born in Scotland Hospital in 1951. So when we talk about commitment, we talk about that's critical. And I know as a premature baby in 1951 who survived and don't have I had bad hyaline membrane disease, so that meant my retina still was okay because of the oxygen. But it was a nurse who decided it was important for my mother to see me when I was 6 days old. So when we think about what is the commitment and what is the importance of people, get stories. The power of the story is so important for us. And sometimes when I look at our websites about recruiting and stuff like that, I don't see our stories. I see the data, and I'm a researcher, so I love data, right? But stories are what's going to really bring us about. So when I reach out or I come to Scotland and I say, see somebody that I happen to teach in nursing school and hear what they've done just because we were able to interact in one class, that's an important thing that I think we're missing when we talk about that. So some of the things, I'm not saying that we've done that as much as we should, but I want to encourage us to think about that story and what is bringing people to our area. Why did those of you who went away to school and came back to work here? Why are you so committed to this community? That's a story we need to be telling. And even those who maybe went away to school and didn't come back, they're still bringing resources back. And if they're giving them a route to come back, giving them a reason to assist, to come back. It may be in a partnership. It may be encouraging a student who is not, can't go to school, can't financially, or doesn't see their way of being in the world. So that's an important thing, because if a student who is here in our high schools or in our junior highs can say, I can see myself doing that. That is one of the most powerful things that will be innovative and stuff. So we need to really be reaching out to them. And of course, we have other things that we're looking at. How do you actually engage with that community? What does that community want? Scotland does a wonderful job with what does this community want and where do they want to be? And so that's the other thing I think we need to talk about when we're looking at, do you really have a good cab? And I'm not talking about somebody who just sits in a seat or has a title, but when we're looking at that community advisory board, what they can tell you what you need. And then they're going to be the ones when we recruit people to help retain them to our community, because they will embrace them in a different way and move forward. Thank you.
Thank you. I love the gathering stories and listening. Tell us how educational institutions like UNC Pembroke are adapting programs to better prepare students for the specific demands of rural healthcare.
Okay, so I'm going to give you an example back here in Scotland, right? So I don't know how long ago now, maybe 20 years ago, Pembroke realized that we were looking, UNC Pembroke was given our RN to BSN program because we had the lowest educational level of nurses in the state. And so reaching out and trying looking, well, who is getting accepted into schools? And then what are they doing? And then how do we help them? So actually we realized and brought up our program here to Scotland. So taking that program out of the classroom at Pembroke and bringing it to Scotland in the classroom really made a difference, because as we were saying, those nurses then could maybe get an opportunity to come downstairs to a class. And I value, and I'm pretty good at online education, but I'm going to tell you there's a wonderful thing about being in the classroom or having that personal connection with the faculty member that's going to encourage you. So that's one example. You may know of North Carolina's Ribbon program, regionally increasing baccalaureate graduates, identifying students early in high school or towards the end of their high school year, and then helping them get not only going to the community college that's a partner, but then working at a healthcare delivery system, and then while they're doing that, finishing that BSN. And that's a good example of what we're doing. But one of the other things I want to talk about that universities need to be looking at is their community assessment. What does your community assessment in your community say your people need? So we've already heard we need radiologists, we need techs. Looking at that community service, that community assessment, and developing the program to do that. And I'm going to give you one more example, then I'll stop. Is that UNC Pembroke, working with the Shep Center, did an assessment of what kind of health professionals are needed in this region of the state, and what do we need to do to address those. And then how do we move and use that as the strategic plan for building the College of Health Sciences at UNC Pembroke. And so optometry was one of the things that we focused on. We do not have a school of optometry in North Carolina, Virginia, or South Carolina. And actually, if I look at how many people who have diabetes and hypertension and not only need the wonderful work that an optometrist can do, because we don't have enough ophthalmologists, right? What can they do to actually move a person's health forward? So lots of times those diseases in the back of the eye are picked up by that optometrist, and then having that referral network so then they can be in partnership together. But that was a long issue to get that, and I'm pleased to say that they have hired their first director for that College of Optometry, and then had to go to the state. Well, how do you build a school of optometry? Because the clinical sites are huge, and And we got support from the Office of Rural Health in our application for the state to get some funding for that. So using the community assessments, using the community diagnosis, listening to the people in your community, they're going to tell you what to do. And often researchers like me at the universities or administrators, they think they know. And I love us, but we think we know a lot, but sometimes we need to be listening with our good ears.
Thank you. So Christy, the next one's to you. How can healthcare organizations leverage community partnerships to strengthen the workforce pipeline to improve retention in rural?
Yeah, so some of our biggest partners are our schools. And so I think that's really important. And so we have great partnerships with our community colleges, with Richmond Community College, Robinson Community College, with our universities at UNC Pembroke, with St. Andrews. I think they are so important. And Dr. Beasley mentioned the community advisory boards, but also the other advisory boards, they listen to our needs. And I think we listen to theirs as well. And so we've been able to create some great partnerships with them, whether it's us providing adjunct faculty. I think that's, a big piece of it as well. We have had our nurses who we supplement because we realize the colleges and universities have challenges as well with salaries. And so we're able to supplement those salaries so that we can provide clinical adjunct instructors, which also gives us access to those students. So, selfishly too, that gives us a hand up for our recruiting. But then also just from the community in general, I think partnering with the community, sponsoring events in the community, we're a sponsor of UNCP Athletics, the Revive After Fives, Laurinburg After Five, those types of things. Because when we can provide things in the community, that helps us retain the people that we bring in. It provides more activities in the community. So I think that's very important too, that the health system is part of that also.
Thank you. And to Maya, in your experience, what strengths can rural communities build on to attract and retain healthcare professionals?
So I'd say getting the word out about our loan repayment programs and working closer with the Office of Rural Health, because we're finding that there are a lot of providers who don't know about the opportunities that they have for loan repayment or a high need service bonus should they not have any loans. And so working closely with us and remembering that we're here to help. It doesn't matter if you guys remember the number or the dollar amount that they're eligible for. If we work together and you just send us your providers, even if we're considering hiring this person, can you have a conversation with them to figure out which loan repayment program would work best for them? We're here for that. And I think that will help providers who are considering coming to North Carolina or coming to rural North Carolina pick us, because we have the opportunities where they can get loan repayment until their loan debt is gone. And then after that, they can apply for the high need service bonus. So those, again, are not just recruitment tools, but they're retention tools also. And we don't, I've had this question a lot. Will we date their contract retroactively from the date they started? Nope. We start the day you apply. So you can have already been there for a year or two, but as a retention tool, we start your contract time commitment the day that you apply. So going forward, we'd be able to at least keep them hopefully for minimum 4 years. And that's just with the loan repayment program, and the high need service bonus is another 4 years. So that's at least 8 years you could get out of a provider. Hopefully they'll stay longer, but I just want to remind everyone that we're here to work with you, fill those spaces, because if we can fill those opportunity gaps, we are then lowering the health professional shortage area scores.
Thank you. And to our entire panel, how do homegrown connections like local talent and community-based education programs play a role in your workforce development strategies?
Well, I'll start this time. So it's already been mentioned about the key relationship with partnerships and looking at what does each need, because it's a reciprocal relationship. But it's relationship. So that's the important thing to remember. But one of the things also that we have to do is looking and working in things like HOSA. HOSA is an organization where students in a high school not just those who are in the maybe a track to get a health credential, are actually saying, I'm interested, I think, in being a doctor. And I tell you, 90% come in and they want to be a physician, right? That's because they don't know about all the other wonderful health professional opportunities there are. And so those local communities being involved in those local high school hosts of things, and then hosting regionally, the hosts of meetings are important. And I think that's a critical thing. The other thing is looking at, I always tell educational institutions, what's your curriculum saying about your community? Does your curriculum, both didactically and clinically, reflect your community in which you're preparing people to be in? Because you have a service area. And so I think the relationship with educational opportunities and regional partnerships, they look at the same service area, but sometimes educational institutions, especially universities, don't think about they have a service area. So one of the important things, you're dealing with this service area, what's important? Do you have a transcultural nursing course? Are you valuing culture as a driver of health? And looking at that, do you have, how much of your clinical is actually not just in a sterile environment, but actually helping that student learn and engage? And if you do that, then they're more likely to stay in your community, as we've already talked about here at Scotland, working with those things. So I think those are important things for us to think about.
Okay, so yeah, I think it's important that we connect with students and show them, like you said, what they can do. We were hosting a group of CTE, Career and Technical Education students here earlier this week, and from Purnell Sweat High School. And so one of our CRNAs, after they had been through their areas and those types of things, he said, I want to come and talk to all of them. I want to tell them what they can do. And so Dr. Lowry, our chief medical officer, is also a graduate of that same high school. And so connecting them with the people who have done it, who have gone and gotten their education and come back and who are doing great things to serve their community, and just showing them and connecting them to those people, I think is really, really important. And so it's exciting too that we were able to show them different areas. And so we had them in radiology and nuclear medicine. And one of the students this morning, I had gotten a report that they had emailed back to the radiology director and said, I want to know more about being a nuclear medicine tech. You know, that was really interesting to me. What do I have to do that? So that was really exciting. So I think that's important, is just connecting them to people who are doing it, because I think sometimes you talked about the stigma of rural and people think, well, I can't do that, or I can't go on and do that. And so showing them and connecting them back to that story, I think, is just so important.
I won't repeat what the two ladies up here with me have said. However, I do agree starting early exposure is something that we have been told as a recruitment placement services team from national conferences that we attend. The earlier you start, the better. So even though we talked about high school, and I remember being part of Medical Explorers in high school, it was longer than I look. It was a long time ago. But I do remember being exposed to that and how important it was. However, at the national level, at the conferences that we attend, they do even suggest starting in middle school. Just exposing them and building those relationships so that when it's time for them to choose their own career path, they at least consider what they've already gotten to learn in the younger years.
Thank you. So and this is to everyone, if you could recommend one policy or programmatic change to address rural healthcare workforce shortages, what would it be?
Is it me? I guess I'll go. We've already talked about the income gap, and that has to be addressed. And are looking at even how we fund our rural hospitals has to be addressed. If you look at something like graduate medical education, we may have interns and stuff, but actually rural facilities get paid less than the large urban centers that have those. So there is not only an income gap once they get here, but the gap to the agency to be able to sponsor those things is important, and it's a strain. The other thing I think that's really important when we think about what would I I recommend when I'm looking at policy is the policy of how we build people's lives. And so we talked about Medicaid expansion earlier, right? What are we going to do to help that child who's in a Medicaid family right now be able to see that they can do this? So sometimes it's looking at our educational programs, because we talk about the drivers of health. What do we have? Are we funding our rural schools at the same rate that we're funding our non-rural schools? And so that's not a health policy, but it's greatly impacting where we're moving. And if I look at those drivers of health, we have to start paying attention to that, because it's important to think about rural people are sicker. They come to the doctor less frequently, and they need some of the intentionality that we can give. But if we're not developing them in our own high schools and our junior highs and our senior highs, middle schools, how are we funding their education? And then giving them an opportunity when they go to school, making sure they come from a family that's poor, looking at that FAFSA. Is it really reflective of what they need? So I would like us to change that policy.
Yeah, I think that's great. And I appreciate the funding for the hospitals, but I would also say the funding for the colleges as well, to make it economically feasible and easier for you to implement programs. So whether it is a physical therapy program, which has been moved to a doctorate program, which has made physical therapy even more challenging because now it's a more expensive program and a longer program, and to turn out enough for what the needs are really across the state, but particularly in rural areas. So I think funding for the colleges, and then also just from the regulations that are required to implement programs and the amount of time that it takes to get those programs implemented is often makes it a challenge to keep up with the demand.
I'd just like to bring attention to the fact that the Office of Rural Health has received an increase in funding that we're able to distribute, and upwards 80 million? 50. I got overzealous. I was excited. I was excited. We advocate for that. Yeah. So we got $50 million extra dollars that we're able to allocate. And so while we're fleshing out the guidelines of how we will be able to distribute it, that does afford us the opportunity to expand our list of eligible provider types. And so one of those is nurses. One of them are behavioral health providers outside of psychiatrists. And so we take pride in the fact that we talked to the people who made the decisions about state budgeting and succeeded. And so now we'll be able to use that written policy to serve more providers and incentivize them to come. It depends on the loan repayment type, but yes. Oh, I'm sorry. The question was, are hospitalists considered an eligible provider type for loan repayment? And the answer is yes.
Okay, well, we are wrapping up our time with our panel, and I'll just give you one closing question. In the spirit of homegrown connections, what advice would you give community leaders and organizations looking to foster lasting connections that benefit both healthcare workers and the communities they serve?
So I would say tell your children, your grandchildren, your nieces, your nephews, your neighbors to choose a career in healthcare. But outside of that, I would just say think outside of the box, collaborate with your partners, really listen. I think that's one thing that I very much value about being here at Scotland. It is a very collaborative environment. And so I think that the listening is there, the ideas are there, and just working through those and just throwing out. It may be something crazy, but just throw it out there and see what happens. Usually you can create something really great from that.
I'd second collaboration. Collaboration amongst the sites, but also with your federal partners and the Office of Rural Health.
And I'm going to say intentionality. If you do not intentionally focus on the needs of rural populations, you're going to miss it. if you're not intentionally focusing on having true partnerships, and I'm not talking about somebody in this silo and their silo and they meet once a month together. I'm really talking about how do I really partner and come up with a creative idea, because together we can make the difference. But if we don't intentionally do it, and I thought I saw one of our members of our General Assembly here earlier, but maybe not. But I want to say, let's talk to them as well. Let's intentionally help them understand the needs of our rural populations in North Carolina.
Thank you. So if we could give a round of applause to our wonderful panel.
Thank you so much to our panelists. We also want to open up the floor for folks in the audience. If you have any questions, how we ask folks in the audience to ask questions is everyone has a mic at their table. Please unmute it once you see it's green. You can ask your question. We want to be respectful of our online counterparts, so making sure that they're able to hear. And then we'll also hand it over to our friends online as well.
Thank you. I thoroughly enjoyed the discussion and your answers. My question is, are any of you, how are you thinking about recruiting people from non-traditional settings? I had the opportunity to visit a residential treatment program that was partnering with a community college to help people in recovery gain skills to enter the workforce. And I wondered whether you all are considering folks who are coming back into various levels of community living as an opportunity for them to develop skills and fill a workforce gap.
I'm going to start with that one, Deb. One of the things I think is stacking credentials. From an educational institution perspective, we need to start stacking the credentials so that you come in, as you're saying, you're a nurse's aide, or you're a peer support, or you're a community health worker. How do we then not expect to go all the way back through? How do we actually build credentialing so that someone who was in a support program and the recipient, and they may get the first credential, second, and they're eventually going to end up being that researcher that we need. But if we don't start stacking credentials, we're not going to get there. We're going to leave them continually behind.
Yeah, I would agree. I think stackable credentials are great. I actually spent 5 years in higher education as well. And so stackable credentials, I think, were very important. And so that is not an area that we've particularly gone into yet, but I think it's something that we definitely need to look into. And I think it's definitely an area that's probably very untapped.
Unfortunately, our loan repayment programs do require full licensure, but that doesn't mean there's not room for advocacy later on should more money become available. So
At $80 million.
right.
But can I say to you, it's not just once they get a license that the stackable credentialing needs to occur. It's once they get, maybe they have a registered nurse or they have a bachelor's degree or something, but then they actually are physical therapy. They need to go back and get that doctorate of physical therapy. And how do we really help that take place?
Any of our folks online? Yes, Maggie, I see you have your hand raised. Can we hear her? There we go.
There we go. Can you hear me? All right.
Yes.
Wow. Great presentation, y'all. Sorry, people know that when I'm online, I do a lot of emojis and things because I'm like, yay, this is great. So just a couple things that I wanted to ask y'all about. So totally agree with the stacking credential piece. Many of you know that I was a speech language pathologist working with assistive technology. Went back to school for because I got tired of patients not being able to pay their bills and not having the kind of technical assistance they needed and the support they needed in their community. So I totally agree with that. And the other thing I think the point is the opportunities for allied health with the situations we have with an aging population in rural North Carolina and other places. OT, PT, and others can be so important to making sure that people can age in place. And so I always think about what are the opportunities for us to support allied health professionals in our rural communities, because I think, you know, we are looking at the economic vitality of rural communities. And oftentimes an OT aide, a PT aide can be, you know, the difference between staying in your home and rehabbing versus having to go into a facility. So, you know, I didn't know if the panel had ideas about how that can work for rural communities and a way to make sure that people can attain some of those skills. I think a lot of times people are thinking about, I have to be a nurse, I have to be a doctor, I have to be all these things. And that may be, you know, the ultimate goal, but we need all of those folks. And I have in the past really tried to advocate for loan repayment for allied health professionals, because if you look at the ratio of cost to their income, it looks a lot like a physician or a nurse if you just simply look at the ratio. So anyway, I'll quit talking, but I'd be interested in the panel's thoughts about that.
Yeah, I think going into a patient's home and meeting the patient where they are is very, very important. You know, one example, we have a community paramedic program that goes out and checks on our patients after discharge, you know, to try to keep them from being readmitted. And so that's been very, very successful. So I think there definitely are opportunities for other health professionals to go into the homes that way as well. But particularly the community paramedics, that's not specifically on the rehab side that you're talking about, but I just think we've seen some good results from that.
Of course, we can't change the National Health Service Corps requirements for loan repayment, but at the state-funded level for loan repayment, perhaps that would be an option. I'm always here for allied health professionals, being a former one myself. So I'm always an advocate for the people who are doing the work, and they're coming to work every day doing exactly what we asked of them, which was serving the medically underserved community. So I don't see a reason to exclude them. We just need more money.
And I think I agree with 100%. And I want to point out that program that Scotland's doing, where they identify nurses' aides and then support them all the way through. And, you know, it can be a seamless transition from that, going through UNC now to a doctor of nursing practice. So those are seamless programs. But I think to get for the allied health piece, one of the things I will say right now, the Lumbee tribe, we've learned to use our security staff to do wellness checks in a community. And so how do you actually then begin to realize that it's not just people with the degrees behind their name that are really critical in our work? And so then how do I look at them? A couple of them said, can you now help us get a community health workers certification? Right. So we got to find the funding for those types of things, because once people get a taste and they get the skill set, they're not afraid to reach in and help. But lots of people want to help. They just don't know how. So we haven't built the path for them.
And just one other thing that I would add is, and because I just had a knee replacement, so of course I'm focused on all that, right? But the PT part of this is so important. I don't mean just coming into my home, because I don't. I go out to get that service. But I think, you know, when you look at where the rehab services are available in the community, even if it's not in the home, how can we support that as a profession for folks? So thank you. I appreciate your answers.
Sorry, I have one question. Thank you all. This is great information. How do you feel like the landscape is on, because I've seen it in several communities. I live out west in the state, where there's great programs, but representation on the communities that they serve is lacking. So how do you feel about recruiting, or like what advice can you give on recruiting, making sure that representation is in the providers pool?
Yeah, so I mean, I think we do have to look outside of our, local areas for that. And I think it goes back to what Dr. Beasley said, is you have to be intentional about it. You got to have a plan for it. It's not something that's just going to happen. And so I think it's something that we have to truly think about and make a plan for it. That's the only way it's going to happen.
And I think going back to the idea that some of our rural schools at the junior high or middle school are poorly funded. And so then they've got to compete for some of the slots. It's not because they're not, I'm American Indian. I'm just as bright as my colleagues that were in some of my other classes. They may have looked down their nose at me initially and didn't think I was. But, so we've got to have those role models, but we've also got to make sure that students have equal access to education. We know that education is a major driver of health. It's also a major driver of educational outcomes. And I think that that's going to help us as well.
Agreed.
I would like to ask a question about resources. So you ladies mentioned a lot of resources that are available. Do you feel like, or do you see that those resources are being utilized to their max capacity? And if not, what do you see the challenges are for that, and how do you think they could be addressed?
I'll say just internally for resources, I will tell you, we used every dollar of our tuition assistance and our workforce pipeline money for the fiscal year that just ended. So we do see those getting utilized. We are filling all of the slots for our legacy program. We're seeing tremendous interest in this new BSN program. So I think internally we are seeing that. I'm interested in our partners, how they're seeing the external resources though.
I will say that I don't think we're using as much as available, Lisa. But so the question was, are all of our resources being utilized? But I think the other important thing is when you have a person who, say, starts like UNCP's now occupational health program, which just started this semester. If a student they may say they have a hardship, and then figuring out, an unexpected bill, how do we help them through that? And how many of our students are we losing from that underserved population? Because they come into a situation and they may have had their tuition and books paid and got some, but their car tears up. Or they end up finding that somebody's at home that's sick that they have to help. So I think maybe those are some more additional resources we need to create, because then if a student drops out of school because they cannot pay for their tires or their gas to get there, then it doesn't matter how much their FAFSA said they could have.
And if I could just add to that, also, there's so much more about higher education than just your books and your tires. And you might not even understand how the college system works. I mean, I was first generation college, and I walked into it blindly. I didn't go to the orientation because we couldn't get there. So my first day on campus was the day I drove myself in my car and went to the dorm. Just things like, how do you sign up for a class? I didn't understand drop ad. I worked in high school, so I was like, oh my gosh, I'm only in class how many hours a day? So I thought I could work 40 hours a week and go to school and take 20 hours because I didn't understand. So I think just the support that you need to give at the individual level to help people make it through that first year and not drop out and persevere.
So we need case management for students.
We do. I mean, we do. Yeah, we do. Mm-hmm.
Hi. I want to give an opportunity to our online audience. We have someone who's had their hand raised. So Laura, we'll hand it over to you to ask your question.
Oh, thanks so much. I was actually hoping to be there in person today, but I had an unfortunate accident, so I'm joining online instead. This panel has been amazing. It's been really helpful to hear everybody's perspectives. I am a public health geneticist and researcher, an educator at UNC Chapel Hill. And one of the things that we think is really important is being able to reach all of the communities in North Carolina to talk to people about kind of their public health genetic literacy. And we've been trying to find some opportunities to reach out and build these kinds of authentic partnerships that you all have been talking about. And I was just wondering if there are any resources that you all could share that would help us to understand, how we could find out about events where we might be welcome to come and talk to people, build awareness about genetics for public health. And just talk to people and understand kind of some of their concerns and some of their questions as well. Thank you.
Yeah, so here at Scotland, we have a phenomenal community health team. And so I think they would be a great team to connect with. They have events throughout our service areas on a regular basis. They're out not just in business and industry, but also just in the community. They're at all kinds of different events. And so we have a great community health team. Also, they're sitting over here to my right, a lot of them, they are great as well. And so they are really connecting one-on-one with our patients as well in the homes. And so I think they're another great resource that could be of help as well for our service area.
So from the educational institution's perspective, I think part of it is making sure that maybe your area is offering to be guest lecturers in classes, because you've got to develop that interest and connectivity to the people who are going to be graduating, who can then go back into those communities to work. One of the things I will tell you, I've been on a genetic project with NIH in our own Robeson County, and genetics itself throws up a lot of questions. So I had written a grant with NIH to say, can we ask the communities from whom they would like to learn information about genetics and what they're willing to trust us giving them? And so, but NIH didn't think that was a researchable project, so that's okay. But so I think those of you who are in that area need to be asking that question. Who do they want the message from? And then helping them, educational opportunities, institutions, community health groups, public health departments be able to provide that.
Thank you. So as a facilitator who was going to give everybody a few minutes to get to lunch, and the audience said no, we are loving this panel and we're loving this dialogue to go after lunch. Highest compliments to each of you, because I always say you never get in between people and their food. And they said, and this group said, no, we love this panel so much. We're gonna keep going. So thank you so much. And thanks everyone for your engagement and your questions. And I'm gonna turn it over to Justin.
Thanks so much for bearing with us, y'all. What we're going to invite folks to do, lunch is not quite ready yet. So what we'll say is, if we want, we can stand up, we can head out, maybe we can take a brief walk outside, talk amongst ourselves until that time is ready. How about maybe like 5-10 minutes? We'll take a 10-minute break. And folks, I know there are still questions in the room, so if you want to come and speak to our panelists separately, we invite you to do that. We'll see you back here in 10.
Thank you.
Restrooms are out to the left if you need to use those. I want to let folks know that it looks like lunch is ready. It looks like lunch is ready. So whenever you're ready to grab a plate, feel free to do so. We've got some Southern soul food. We got some North Carolina sweet potatoes. My favorite, collard greens. Maybe some fried green tomatoes. Looks great. Yummy. Louder. Yeah, the food. Mmm. It's ready for you, folks. And got some Southern soul food. Our folks online, feel free to grab some lunch. Do what you need to do. We're going to have our keynote speaker join us here in a few moments. Once we get settled in the room, maybe a stretch break is in order, who knows?
Oh, sorry. Hold on, I'm sorry.
I hope everyone is enjoying their lunch. I hope everyone's enjoying their lunch. It's so good to be sharing a meal with one another. As we're all settling in and before we hear from our keynote speaker, I wanted to give an opportunity to our partners at North Carolina AHEC to share a little bit about the resources that they have available to those folks in the room. I want to do that though.
All right, yeah, we're gonna have a little bit of a teacher second. If you can hear me, clap twice. If you can hear me, clap once. Perfect.
I'm so sorry. So I wanted to, before we hear from our keynote speaker today, I wanted to give an opportunity to our colleagues at North Carolina AHEC to share a little bit about the resources that they have available with those in the room. So I'm going to pass around the mic to these folks, and we got the camera on you. So take it away, Paul.
Hi, I'm Paula Locklear. I work at Southern Regional AHEC, which is in Fayetteville, and I'll let everybody introduce their who they are and what location they're from, and then we'll have like a little synopsis, and we'll appoint Donna to tell you a little bit about AHEC and what we do.
My name is Jackie Calderon, and I'm with CHEC, which is Southeastern AHEC down over in Wilmington. And I serve a lot of the rural health clinics in our area. I'm glad to be here and see everybody. A lot of familiar faces in the room, so I'm glad to be here.
Hello, everybody. I am Donna Bowen. I'm with Southern Regional AHEC, same place as Paula. We work together as a team. We are a part of the practice support branch of Southern Regional AHEC, and we're happy to be here.
Good afternoon, everyone. If I had known that I was going to have to get up here, I probably wouldn't have agreed to do that. Team effort. My name is Robert Shapiro. I'm the director of the library with Southeast AHEC. So I serve as a librarian, and my library serves all of the healthcare professional, the entire healthcare workforce in Brunswick, Columbus, Duplin, Pender, and New Hanover counties. But I get to represent, I guess, all of the library services team throughout AHEC. So every single one of our counties is served by a librarian and a library. We have an AHEC digital library that we offer to everyone in the state. So pass it back over to Donna. Yeah.
Okay, so number one, I will tell you, he said if he had only had to speak, he wouldn't have got up here. Well, I thought we were coming up here to take a picture.
Yeah, that's what I was told too.
So I'm going to tell you a little bit about AHEC as a whole. AHEC stands for Area Healthcare Education Center, if you are not familiar with that acronym. We have different branches. We have the practice support, we have CPD, and we have the library. And then some of our actual AHEC facilities have practices within the walls of their AHEC. So we have a family practice and a specialty clinic within our walls. And MAHEC also has, which is the mountain area, has a clinic as well in their AHEC facility. Practice support is is a branch of AHEC that we go out into the communities of North Carolina, especially the rural communities, and we help practices with whatever needs they may have. If you've got issues with quality metrics, if you're working on Medicare MIPS, we can help you with your quality metrics. We can help you with your EHR optimization. I lost my train of thought for just a minute. With your EHR optimization, we can help you with Medicaid managed care. If you're dealing with Medicaid expansion, we can help you with those things. We have an abundance of different disciplines on our teams across North Carolina. We got former practice managers, we've got nurses, we've got IT quality personnel that work on our team as well. So we've got a lot of expertise on our team. We've got over 40 coaches in our AHEC, and with those 40 coaches comes a lot of experience. And if we don't know the answer, if we're in your practice and you've got a question and we're not able to answer it, we can reach out to our team. So we have great resources that we can get answers for you. Also, our CPD department has a lot of educational opportunities that they do as far as nursing, and we have an AHEC Scholars Program for nurses and for pharmacists. So if you haven't heard of AHEC and you want to see if you've got an AHEC coach out there or you've got an AHEC facility in your region, please just Google North Carolina Area Health Education Center or North Carolina AHEC, and you will find, and there's a lot of resources on that website that can get you to who you need. Also, we have something called a Practice Management Academy, and that started 2 years ago, and it's a program that we have for practice managers across the state, and it helps with if you don't have any experiences being a practice manager, if you have 2 years experience being a practice manager, it gives you customer service and all of those resources that you can do to use and learn to become a better practice manager. We're also starting a dental practice management academy in January. So it is growing and we're very excited. So I'm sorry I've been long-winded, but I just wanted to make sure that you all understood what AHEC is and how we function and what we do.
All us, we're here.
Our keynote speaker this afternoon is Dr. Thomas Ricketts. In his retirement, he holds these roles: Senior Policy Fellow at the Shep Center for Health Services Research, Adjunct Professor of Health Policy and Management and Social Medicine at the UNC Gilling School of Global Public Health and the UNC School of Medicine. If you had a list of everything that he continues to do, it wouldn't fit on the page. And I don't speak French, and so I can't even describe the appointment to faculty he has in Paris. But if you've been blessed in your life, then there are special folks that weave through your life like a thread, and I have been. And you find that the way that your lives intersect with these people, not for very long periods of time, and sometimes there's gaps of decades in between, but you find you are blessed by these folks. Healthcare is a small world, and my world has personally been made much better and brighter for the existence of Tom Ricketts. Tom is somebody as a professor who taught me to think, and then he challenged me to act. He balances being a realist with being an idealist. He spent his life researching and teaching to improve the health of rural North Carolinians. So please, if you would, welcome our keynote speaker and my public health hero, Tom Ricketts.
Goodness. Thank you very much, David. It's a great honor to be here. I'm what could go wrong? I'm approaching my 76th birthday next month, and I played football at high school and college, and then 20 years playing rugby and was subject to a lot of concussions. And along with the age and then the very intensive lunch thing, what could go wrong, you know? But I'll try and keep you awake, but if you do, please don't land in your plate. It'll be all right. So David asked me to come to Laurinburg, talk about rural health. It's National Rural Health Day. That's something that's important to me, and something I thought I've always thought it was important since I went to the School of Public Health in the 1970s. And it's something that I heard about and studied, and because the people around me at the School of Public Health were special people who did rural health. In 1970s, that was a new thing. I didn't know it was a new thing. I thought it was something everybody did. So when they were creating the Office of Rural Health, that seemed to be a logical thing. But when I learned that it was the first, I realized how potentially illogical it was. Since then, I've studied. I got hooked into the job by a guy named Cecil Sheps. If you haven't ever heard of Cecil Sheps, he's really the person who brought all this about, who brought Jim Bernstein, who brought a number of other people and created something, was involved in the creation of something called community-oriented primary care. But I've been involved in the research end, which means that I'm somewhat on the outside, but I am an academic, so if I'll provide you with the footnotes after the discussion if you need that. So, but I started in this, and it wasn't a field at the time when I started, but it's grown into something very important. And as you've heard, there are millions of rural people, millions of North Carolinians are classified as rural, 3,474,661 to be exact. That's how much I'm an academic. Want to be precise, but I'm a little entrepreneurial as well. I'm, looking at rural health, I said, well, I'm in a research center. We need to organize a center for rural health. And we became the first center for rural health in the United States. And I was, entertained by this, the newness of this thing until someone asked me, well, if you're so smart, how many hospitals had closed? You keep saying that's a problem. And I didn't know when I was asked. That was by a reporter from WRAL-TV when we opened the Center for Rural Health Research. And we've spent the last 30 years documenting rural hospital closings. At the time, there were 5 that closed across the United States. And, we're going, that's a terrible thing. Now, we've had, hundreds of rural hospitals close. And it's quite a disturbing event in many places when the hospital closes. And in one place in Alabama where I visited, and they lost the best restaurant because that's where you went to eat, because they had the best people in the hospital. So rural hospitals do more than just take care of people. They feed the hearts and minds and the bellies of the residents of rural places. Being, I learned early on that what I was trying to do was develop a sense of place. Now, you all have a sense of place here in Laurinburg. I mean, you've heard it by several people testifying essentially to the sense of place. And that's a really important thing, that people have to have a sense of place, not only from where they came from, where they want to be, but where they are now. So I'm glad to see that David is committed to creating a sense of place here in Laurinburg. You think there's a handy definition of rural health, and that the government pays attention to that. But in the Department of Health and Human Services, there's an Office of Rural Health. But in the Centers for Disease and Control, Centers for Disease Control and Prevention, there wasn't an Office of Rural Health until last year. They've organized an Office of Rural Health. So It takes a little while. It hasn't been, it's been 50 years, but surprisingly, some elements of the federal government haven't gotten the message. Rural health is a symbol. It's a symbol. It's a symbolic condition of the health of part of the nation, of our fellow citizens. It's a symbol that some people consider a condition, because when they say rural health is worse than the rest of the nation, they're talking about it as a condition. Now, I'm going to talk about the difference between conditions and problems, because I want you to understand that when you're a condition, you just have it. When you're a problem, you solve it. So I'm saying, let's find more problems. Let's get, away from having conditions. As a symbol, rural health can be useful when we're looking to define the problems, but only if we simultaneously associate solutions with those problems. Again, saying something is a problem means you are intending to solve it. In North Carolina, we did an important thing to and for rural health. We changed rural health from suffering a condition to becoming a problem. And you don't want to necessarily say that when you're on the road from the Office of Rural Health, but basically, really, we wanted to create the idea that there are problems that can be solved. So this transformation from conditions to problems is an important process. And we see new problems, new conditions, drug addiction, problems like that, motor vehicle accidents. Those things are seen as conditions sometimes rather than problems. So our challenge sometimes is to make it obvious to some people that there are problems that we can solve. When you talk about rural residents and what their problems are, you talk about they have higher rates of cigarette smoking. North Carolina used to not be able to say that. We took, from my high school, Fayetteville High School, we would take trips up to the American Tobacco Company, and we were all given a carton of cigarettes to take back home. But it's still a problem. High blood pressure, obesity are all much higher in rural places than urban places. Extended chronic disease. In other words, you can get better faster in an urban place than you do in a rural place. Rural Americans are more likely to die prematurely from leading causes of death, heart disease, and cancer. They're 14% more likely to die of traumatic injury. And not just shotgun accidents, but accidents in the home, automobile accidents, and interpersonal injury. Rural places have higher rates of poverty, less access to health care measured by proximity, and the resources that support those people. Rural places have more uninsured residents, as well as higher levels of unemployment associated with lower health status. Inequity, that's what it is, health inequity between rural and urban places. Now, when you have a list like this, and you talk about, describe all of the problems, some people call this admiring the problem. We want to turn it from admiring the problem, talking about it in those terms, to talking about it as, let's think about it as a set of solutions that are going to be married to these problems. And the Office of Rural Health, Scotland Hospital, these are parts of the solution set, the community of solution. Now, people talk a lot about communities, and you talked about the communities of need, the people who are out there suffering these kinds of health challenges. But there are communities of solution, and I want to talk about those in a second. Communities in this state is something we take responsibility for in North Carolina, and that's the Office of Rural Health is one of those, but AHEC, it's true what they do. You call them up, and if you want to find out some information that's on the net and you can't figure out how to do it, AHEC is the place to call. We've had an Office of Rural Health for 51 years, and that office has been shaping a community in the state as people, try to improve health in their home communities. The Community Office of Rural Health has a community of solution throughout the state, and that's good. That's a wonderful thing. And it brings in academics, government, healthcare systems all together to form communities of solution. And those communities of solution have to overlap with the communities of problem. So it's a difficult balance when you're talking about problems and you want to talk about solutions in the same way, because sometimes they drift over into conditions. We can't do anything about this because of the problem being in a rural place. Now, the importance of community, is highlighted by the fact that Jim Bernstein, when he came to North Carolina, he came as a global community health fellow, not a rural health fellow, a community health fellow. And that was a program that was sponsored by the Public Health Service. And he was one of 3 fellows who came to Chapel Hill under this program. Mike Samuels, who concentrated on health professional recruitment in communities, and he went into the National Health Service Corps. And Ted Parrish, who was interested in community-based health education, and he went into to NC Central and then to UNC as a teacher. And Jim Bernstein, of course, created the Office of Rural Health. But the focus was on community because they had learned something about community health services. It was called community-oriented primary care. And a group of people came from South Africa, of all places, because they had created a system of care in localities, in rural localities in South Africa. Folela was the central place. It was called community-oriented primary care, and basically involved in, engaging the community, training the community to provide them with the health services they needed. That their problems, they were allowed to define their problems, that they were allowed to tell the practitioners and the people who were, in the white coats, what they needed and what they wanted. And that community-oriented primary care became a symbol and a way of doing things that we benefited from when the South African government turned into apartheid and chased all of those people from Folela away, the Folela Clinic, and they eventually, all but one, came and settled in Chapel Hill, either at UNC or Duke. And they began to proselytize this community-oriented primary care thing, and Jim Bernstein was one of their students. So I talked about creating or identifying a thing as a problem. That is, we sometimes have to redefine something that we see as a condition, lack of access to primary care, redefining it as a solvable problem. Primary care is insufficient today, but we can build it to where it meets our needs later on if we do these things, bringing a solution into the discussion of the problem. Now, I call that, when you have to join people together to create these solutions, is creating a community of solution. Now, the community of solution, like Raleigh, it's up in Raleigh, has to be part of the community. It's Washington, D.C. has to be part of the community. It's institutions that train the people that come into Scotland County. Those are your communities of solution. So you can't just isolate yourself in the community of problem. You have to learn to converse and to interact with people who are in the community of solution. The foundation and the Office of Rural Health are basically committed to seeing that this interaction happens. But it doesn't always happen perfectly, and it doesn't always happen easily. What we want to do is expand the community of solution to overlap more and more with the community of problem, helping people own the problem, helping people in Raleigh own the problem, helping people in Rockville, Maryland, at HRSA own the problem, helping people at the University of North Carolina, Chapel Hill own the problem. And so they become then part of the community of solution. Now, these components that I mentioned as community of the communities of solution, they're people that we turn to for help, but the solution also lies within the communities, the local communities themselves. Business, industry, retail, communications, education. We can identify these communities and recognize them as, oh, well, yeah, the realtors, they get together and talk about things, you know, every week, or the Rotarians, or people in the churches. I'm going to say a lot about churches because I've been in rural North Carolina. There are these two types of communities that recognized each other 50 years ago by the foundation of the Office of Rural Health. They recognized that it isn't just the places on the map, but the symbolic perception of those places on the map. What do people think about Scotland County? And sometimes that imagery has to be massaged a little bit. And basically, all I have to do is bring you down to see what Scotland Health is doing to give you a sense that this is a real vibrant healthcare community. But there's still things that can be done. Now, I talked about symbols. Symbols we associate with things like religion, or with the work we do, the schools we attend, as well as healthcare. Even the places we shop and the brands we buy, we identify with them. And sometimes you can, form community by common identification of certain symbols. Recently, I bonded with a very nice lady over mayonnaise. She was reaching for Hellman's, and I said, try Duke's. And I'm from Richmond, so it has to be Duke's. So symbols that define communities are sometimes common needs, common wounds, and the hurt of history. They can bring people together. These communities of needs and wounds and hurts can also be turned into communities of solutions with care, with caring solutions. When I spoke with people in rural communities about their health and health care, and those to whom they turned to get help for their health problems, they talked about as much about their church as their clinic, their pastor or priest as much as their doctor. They talked about their work and their economic situation and the people that employed them as much as their hospital. So you don't want those realities to be parallel and separate. You want to see them integrated, because that's what people relate to in terms of their communities. These symbolic places and people came up in conversations when we were talking about what needed to be done. And there's probably more potential than you're aware of, even for those people who've lived in a community for a very long time. I have gone through communities in parts all over the United States and introduced people who didn't know that somebody was doing what other people were doing that could be helpful in healthcare. There's probably more potential than you are aware of. I read in the Scotland County Community Health Assessment that there are close to 150 churches in the county. I think I passed about 50 of them on the way down. Said one of those churches offered a dental service, a free dental clinic, until COVID stopped it. That's the kind of thing that can be done again and again and again. But they don't have to last forever. Believe it or not, 5 years happens in a real quick time. And if you get 5 years of a cooperative project out of a church or a fellowship group, that's a pretty good return. You just have to turn over and let those people, ease on out and bring on new people. Churches aren't the only wellspring of a community, but they more often than step up when there's a need. I'm not a very religious person, but I recognize the power of churches because I was born in Richmond, Virginia. I had a Baptist grandmother on one side and a Catholic grandmother on the other side. I went to, morning service at the Monument Heights Baptist Church, then went to St. Patrick's Cathedral where I served Mass. And then I went back to Monument Heights to where they put me in water, and which I didn't understand, but I've had a lot of religion, enough to last me another decade, perhaps. Now, I learned something. I also lived in Japan. My father was in the military. We lived at Pope Air Force Base for quite a while. But we learned about something over there that is a strategy in manufacturing and in business over there called managing by wandering around. Managers or leaders making unannounced visits to parts of their factories or institutions. In the Toyota Motor Company, these were called Gemba walks. But they were also more often called LWs or leader walks. And they were seen as an effective way to fix the problems in production and performance because the managers visited the workers on their turf. They felt they could tell you what was wrong. And the managers were obligated to do something about it. To learn about communities and how they work or don't work in health and healthcare, I learned to wander around a place, to talk to people more or less at random. I learned this part of a large national research project intended to evaluate the Rural Access Program for the Robert Wood Johnson Foundation. The foundation was kind of enlightened because they were interested more about the broader effects of the programs than the specific clinical or technical outcomes. So they looked for options of how to study their impact beyond the scientific purity of standardized methods used in evaluation. And you don't see this kind of latitude very often in the research world, but I came in and remembering the Toyota wandering around, I said, well, I'll give it a try and go to these communities and just ask people what they think and what they feel and what they know. So I trained a few people in this process, and it's actually a thing in research. Journalists do it, but we're chasing them away. But journalists call it, and qualitative researchers learn to go out there and just ask people what they think. I tried this out as part of a formal evaluation strategy. Wandering around helped me identify the various communities in a place, the institutions, clubs, churches, neighborhoods, neighborhood associations, antagonistic neighborhood associations of people who are trying to get the two-stroke blowers out of the neighborhood. Hangouts, breakfast or lunch places. These were part of the geographic community as well as the sociological community that surrounded a clinic or a hospital. These were the things that we were evaluating, but we needed to go out there and talk to people on their turf as to what they thought about and what they needed out of that institution. Where's a good place to get breakfast around here? Was a good thing to start. Or how can I get to lunch? Jim Bernstein would always eat in the community he visited. And he knew where the good places were. And sometimes you were forced to eat in the bad places. But you'd ask, okay, well, if you meet up and talk with somebody, what's the history of this building? It looks interesting. And somebody, 3 or 4 people are going to tell you, I don't know, but somebody's going to engage with you about how it was built by his great uncle or her grandmother or something like that. These community institutions, they're institutional memories that you have to tap into and institutional knowledge. So I did this and I learned a lot about what was being done, what needed to be done, and how it could be done. For example, in a community not far from here, a more arrogant county to the north, there was a hospital having a hard time understanding why people were coming to them so late in an illness or after the effects of an untreated injury or a condition. They come into their emergency room, very ineffective, inefficient way to treat what is could be common problem that a little preventive services would help. The hospital administrator asked, why were these people coming to the emergency room brought to me by the sheriff's department? Why are they not being referred to by the clinic, the formal system? Why they are accessing the system inappropriately? Well, they're accessing it the only way they knew to get information about how to do it. Now, it was costing this system a lot of money. So I wandered around and began to ask people, what were things, why was this happening? I went and talked to the policemen, sheriffs, the sheriff's deputies, business people, just hanging around on the street. After a while, I noticed that they, as often as not, sent me to some out-of-the-way church or a pastor or a deacon, to their homes who knew a person who would drive older people to the clinic or, along with taking them to get food. I learned about community thrift stores. You would never know that they were there. The role of the pharmacy and pharmacist in providing information. And sometimes not so great information, but at least they were not doing, harm. There was a much broader referral network than was apparent. By wandering around, I began to see this network. It was very deep, very, very, very happy to do the referral of people and to listen to their problems, but they weren't necessarily doing it on time and as efficiently and accurately as possible. The thrift stores were especially great for information hubs because everybody knows whatever somebody had that they're selling. They're getting rid of an heirloom, and the story of that, and the story of the extended family. So if I would recommend any kind of information gathering process, I'd say go and find the thrift stores or the secondhand stores and things like that. But one thing among many things that I found was that how wide, varied, and numerous were the churches and fellowship associations, the faith community that existed in a place, the web of communications that these churches created, and how they served as the transportation, in a sense, referral network for healthcare for much of the population. Now, this doesn't come as a surprise to most in the room, but really it's deeper and broader than you think. But it also has problems that all they need is a little more information for them to do a better job of what they want to do, which is the right thing. There are unseen social clubs and organizations that I and the people who hired me had never heard of. I mean, I meet once a week with a group of people who are architects and planners, lawyers, whatever. It's been meeting for Thursday afternoons for 22 years at a place called the Dead Mule Club. Well, that was, you think that's just for fun, have a few beers, things like that. But no, they got involved in zoning problems of some healthcare offices that wanted to set up, but were being thwarted by the Chapel Hill and Carrboro government. So it's fascinating. That's my Thursday night drinking club solved the problem and got a clinic put in the right place. Now, this existence of sort of informal groups won't surprise many of you. You know about them. And they've been tied to healthcare. Healthcare is hospital, comes from hospice, which is a place of religious people, where set up a place for people to come and, take a break. And there it is. But you won't, the kind of thing I'm describing won't surprise you. Fellowship is a real thing and could be harnessed more and better to help you do your job the way you want to do it. But many of you know that their faith communities can be a barrier, if you will, to health communication, health connections. It's just they need a little education, but you don't want to call it education. Counseling, involvement, engagement, fellowship, that sort of gentle, communication process It's difficult to do, but it is something that can be done. And I look around the room and there are people here who can do it and can do it. This is the kind of, the world of loose connections or social bonds that we need to have in a community. And it has to be taught and influenced gently. So I say, don't send me out there. Send somebody who's a little bit different from me. But I can tell you that they might need, what I can tell you is they might need to have that advice. It's one thing to identify a network of connections in a place, and then, I can publish in a sociology journal, and another to navigate a real place. But we have to do it with intention. Look into yourself and say, hey, look, what am I doing here? And as a researcher, I'm just a researcher. I couldn't solve the problems. A lot of people want to solve problems that they see, but it's not their role. So you've got to shift your role of solving a problem sometimes to the people who really can solve the problems. Now, social workers in Department of Social Work, and they're here, do this all day long, but they're overwhelmed. And the problem is bigger than their capacity. So they have to offload some of this social work. Now, it's one thing they tell a doctor or a physician, hey, look, you got to do some of the social work stuff, talk about, the wrong approach to it. But there are ways to convince physicians to get out in the community a little bit more, of nurses as well, of any kind of people, of hospital administrators to wander around. So I think that, if there's one thing that I'd hope that would be done is that there'd be a little more informality to some of the community connections. One day a week, you had to kind of design it yourself. And people get out there and do those kinds of communications that will help create communities of solution. So communities of solution, shift, and change as often as the weather. You can do it for 4 months, 6 months, a year, perhaps. So you got to have flexibility in your solutions. You have to remember people get born, grow up, die, go away. They're going to be different people every day. And every day you're a different person. And every day the community is made up of different people because they learned something the day before. So you have to keep up with their learning. You have to keep up with the kinds of things that affect their lives. Now, in a place like Laurinburg, you'll know when a commercial business or a plant or something